this is actually not a business update, but Bev and my team, can you pull the report? So I really want to do this in 6 minutes or less, but every year at the spring meeting, we distribute the information that we've been able to glean from claims records about each of your individual PCP panels, about the metrics of your oversight of your panel of SoundPath Health patients, and about where those patients receive services by type of service. It's sort of the annual PCP report card. Again, tonight we have that for you, and I'm going to show you a couple of those reports. Forward. Backwards.
Yeah, you were right. You were right.
I was right before. Okay. Sorry, technology. Okay, so I have two reports that are in the envelopes for you. They are both the capitation versus fee-for-service report and the healthcare utilization by medical service. Capitation versus fee-for-service. This is based on all dates of service to your patients in 2011 paid through March 31 of this year. So 90 days of run-out. Most of your offices are really great about getting us their bills. And so while there may be a couple of stragglers, it is essentially complete because we also get those bills processed quickly. The analysis looks at what your base cap would have been if you're currently fee-for-service with us, or if you are capitated, what that base capitation would have paid, what the member co-pays you should have collected at the office, any separate fee-for-service payments that you were paid for things that are outside of regular cap, and most importantly, for those of you who are also unit holders of the PSW Corporation and enjoy K1 surplus distribution at the end of our business year in addition to the reimbursement for clinical care, none of the K1 surplus that you might have received last year is included. So this is strictly reimbursement for care. The board of PSW has for more than a decade believed that capitation was the preferred method to compensate you fairly. And we have a risk-adjusted capitation that was described earlier that last year resulted in an additional $200,000 in payments to primary care because their patients were more complex. The other thing I would tell you about the data is that if you practice with colleagues, the only way we can pull the data off of our system is by who is the assigned. So if Dr. Wilhelm is the assigned PCP in the system for me, but I saw one of her associates on a day when she was on vacation, Dr. Wilhelm gets credit for the monthly cap payment, but her friend and colleague gets hit with the fee-for-service cost. And so to the extent that you share patients within your practice, the individual clinician data is going to be skewed, but at the entire practice level, it will be accurate. Last year, this time, we reported that for primary care, that the capitation methodology resulted in an equivalent payment of 155% of Medicare. So it's as good or better than probably many of your commercial clients. This year, the good news is, overall, on average, went up 11%, 166%. So this is how you read the report. Each of your reports will have the PSW number. After tonight, you all know what the RAF is. That's that risk adjustment factor where 1.0, based on the codes that were submitted, is average. The total member months in your panel over the 12 months, what that means in terms of the average membership over the calendar year, how many primary care encounters those patients assigned to your clinic experienced in the year, and therefore the number of primary care encounters per member per year. What your base cap was, what the co-pays and any additional carve-out fee-for-service payments should have brought into your practice. If you and your colleagues were part of the 50 of 138 PCPs who earned enhanced cap because of risk adjustment at least 1 month, and therefore the net capitation total payment. And then what we did, because the majority of you are capped, is we reran your bills as if the patient had had traditional Medicare with or without a supplement, and what you would have collected. And so overall, last year, the combined PSW primary care pools made almost $1 million more than you would have had those members not selected SoundPath Health and had you not been compensated under capitation. I would warn you that, again, if you're a group, you really need to look at the clinic overall, because the fact that your patients are seen otherwise. Of the 32 practices that were with us for the whole year and submitted bills, there was only one practice that would have done better had that clinician not been, had that clinician's patients been on traditional Medicare. And that particular practice has a panel of 10 and lost $1,500 compared to traditional Medicare. But that clinician is a unit holder member of the PSW Corporation, and that person's K1 surplus more than exceeded that. So even in that case, but that tells us that overall, and in that clinician, the number of encounters per member per year was almost 7. So that clinician was seeing his patients, and I would submit, likely rightly so, far more often, and I would presume that the RAF score is low and that the premium should have been higher, and that if we'd been able to risk adjust the monthly cap, that he would have been there before. But 1 out of 32 isn't bad. So look at your report. If you have any question about it, let me know. Comparative cost of care. This is just to let you know, and I apologize it's busy, but in your packets you've got the complete schedule. But what I wanted to show you was what happened between 2010 and 2011, that the number of member months, our enrollment in SoundPath Health increased by 67% in 1 year. So we thank you for supporting your patients when they asked you, should they consider SoundPath Health. The number of member months capped, so for last year, 42,000 enrollee months, and 35,000 of them, the PCP is on a capitation formula. So you'll see that the capitated number went up a little less, meaning that more of the growth was in practices that have not yet discovered the advantage of capitation. But you'll note that in 2010 we didn't break out the risk-adjusted cap differently because it was new. But overall, when you combine the 3426, which is the net rate, anyway, these numbers are real. We've been playing with them for a week and a half after we got them, so they're solid. Primary care compensation overall went up 7% compared to last year in the combination of base and the enhanced cap. But if you can see where the real money is in when your patients are hospitalized, so anything we can do to better coordinate care and prevent hospitalizations and ER trips, that's where the lion's share of the money goes. Skilled nursing is second in terms of the overall costs, and it goes down otherwise. So you can see where these Medicare Advantage patients are receiving care. But if you look at the bottom, the grand total, last year it cost us $583.50 per member month to provide all the medical services that your patients needed. In 2011, we reduced that cost by almost $23 per member per month, which is great. The problem we have, and this is the only business piece, and that's why the accurate coding in RAF is so important is that overall PSW's average RAF declined from 0.94 to 0.88, which was a 7% reduction because we didn't document and code correctly. And that meant we lost $93 a month in premium in 1 year. So it's better quality to document and to have systems in place. It'll be better when we can clinically integrate and coordinate. And for your practice individually and your panel overall, we gave you PSW's aggregate numbers. And again, I would encourage you to look and see if there's a real difference. You know, if your RAF is low but your costs are high, figure out where, and we can do a deep dive. If any of you want us to look at which of your patients, we can get right down to the details. So at any rate, we hope this is useful to you, and we thank you, as always, for the wonderful support that you give each other, your patients, and the team of us at PSW. I would be remiss if I didn't thank the board, who are wonderful for all of us to work with, and my staff. Will my staff stand? I'd like you to all give them a hand. They are phenomenal people, and they work so hard every day. And the last thing I'm going to say before turning it over to Dr. Goen is a very sincere thank you to Dr. Young and Yogeni and Dr. Jump and Arif and Hiroshi and Dr. Fayola for spending the time to help us understand their perspectives. And a special thanks again to Tim Dowling and West Coast Bank for making this meeting possible. Thank you.